Good evening, everybody, and welcome all of you to this live program at Orthopedic Principles. Today, our guest of honor is Dr. Hitesh Shah from KMC Manipal, India. Dr. Shah is currently Professor of Pediatric Orthopedics in KMC Manipal, India. After completing his residency at the BJMC Ahmedabad, he joined the prestigious Department of Pediatric Orthopedics at KMC Manipal in 2002. Dr. Shah has close to 100 peer-reviewed publications in high-impact journals. He's a member of the International Perthes Disease Study Group, which is a community of surgeons researching about Perthes disease. He also serves as the treasurer of Pediatric Orthopedic Society of India. If you notice, Dr. Shah has delivered a lecture on our channel and it's already reached a huge audience. And today it's my great honor to bring back Professor Hitesh Shah for this wonderful live program. Over to you, Dr. Shah.
Thank you. Thank you, Dr. Gopalan, for the kind introduction. Okay, coming to my topic, the Coxa Vara in children. So it's very commonly asked the question in the postgraduate MS Ortho and DNB examination. So I have prepared the talk according to the MS Ortho and DNB examination. I'm going to discuss today the normal alignment of the pediatric hip, the etiology of the Coxa Vara, what are the etiology can affect the proximal femur geometry into Coxa Vara, assessment and variables to be considered for the managing the patient with the Coxa Vara, management principles and few techniques, complication and prevention of the Coxa Vara. It's very commonly kept the case in exam, but all the Coxa Vara in children would not be same. So for understanding the Coxa Vara, we need to understand the normal alignment of the child hip. The development of the proximal femur geometry varies from the infancy to the adult. And if we see the child at the first year of life, the neck shaft angle would be 150, and at the maturity or near maturity, it will reach to the 125. So we cannot extrapolate the definition of the Coxa Vara depends on the neck shaft angle because it varies, and the remodeling of the proximal femur changes from the valgus position to the varus position in the adulthood. Similarly, the anteversion of the proximal femur and acetabulum also changes. The proximal acetafemur and acetabulum will go together for the development of the proximal femur and acetabulum geometry. So whenever the neck shaft angle of the affected hip is less than 5th percentile of the normal side of the neck shaft angle, it would be considered as the Coxa Vara. It is very important to say what we are talking about the same age. In adult, we'll say about the neck shaft angle less than 120 degree, it will be considered as a 110 degree would be considered as a Coxa Vara, but that may not be true. If the child is born with 150 neck shaft angle, and if we say 110, it would be a Coxa Vara, that would be not true. So the ideal definition would be the neck shaft angle would be less than 2 standard deviation of the average of the same age group. So coming to the etiology of the Coxa Vara, what are the common etiological presentation of the Coxa Vara? The commonest at the birth would be congenital cause would be proximal femur focal deficit or the congenital short femur, or new terminology CFD, congenital femoral deficiency, would be a very common to have associated Coxa Vara. Second would be the developmental Coxa Vara, when as the child grows without any reason, effect happens at the proximal orientation of the proximal physis would not be in a normal orientation, can lead to the Coxa Vara. It is not uncommon in our country to have a post-septic where there is the proximal growth plate would be affected asymmetrically, where the medial and lateral would be affected asymmetrically. That would be damage of the proximal femur, neck, and the shaft or the subtrochanteric area. That can lead to the post-septic Coxa Vara. Another reason very common in a childhood where there is a neck femur fracture that can lead to the malunion or a non-union proximal femur as in adult will definitely go for the varus angulation, and that can lead to the also coxa vara. Very common to have the tumor that is a benign in nature, that is a fibrous dysplasia or the simple bone cyst. If it has not been treated, that can lead to the typical separate crook deformity in the fibrous dysplasia, and that also can be presented as a coxa vara. The metabolic bone disease or the collagen disorder in a child, it's common to have the osteogenesis, that is the osteopenic condition of the proximal femur that can also present with the, because of the repeated fracture, is a microfracture and a macrofracture of the neck that can lead to the coxa vara. Very common to have Perthes disease in this part of the world, and because of the growth arrest of the proximal femur with the normal pace of the greater trochanter, we may have the actual coxa vara or functional coxa vara or a greater trochanteric overgrowth due to the Perthes disease. In adolescent age group, we need to have the adolescent coxa vara, that would be nothing other than the slip capital femoral epiphysis. Whenever the obese child with primary or secondary causes of the proximal femur geometry disturbance in adolescent, that can lead to the slip capital femoral epiphysis, and that can have a coxa vara. Very common another things would be the spondyloepiphyseal dysplasia or spondylometaphyseal dysplasia, that will be affecting the growth of the entire throughout the skeleton with the proximal femur, that will lead to the symmetrical or sometimes asymmetrical coxa vara, and many times it will be the cause would be unknown. So the very important question when the child present with the coxa vara, the first and final goal would be to find out what could be the etiology of disease, and we can find out by the very careful examination of the history. If we see about what need to check, or for the exam, if you see about the case of the coxa vara, what are the factors we need to check, that's we need to say the age of the child. If the child is young with a tremendous growth potential or the near the skeletal maturity, whether it would be associated with the pain or the painless. Most of the congenital and developmental disorder would be associated with without pain. However, the infection or the osteopenic condition or a fracture condition would be associated with the painful condition. Very important to find out whether it is a progressive or a static. In case of the growth arrest of the proximal femur, it would be a progressive disorder. And other than the growth plate, whether the malunion or the microfracture, that would be a static disorder. The management differ in a progressive and the static disorder. What are the functional incapability of the patient? Whether the patient has got the mechanical pain, whether it's a progressive deformity, whether it's a limp, whether it's a painful limp, whether it's a painless limp, difficulty in abducting the hip, or mechanical type of pain in a long standing, that can be asked whenever we treat the patient with the coxa vara. The clinical assessment, there are the many tests like a telescopic Trenberg, but the most important test for the diagnosing a coxa vara is the range of motion. And the important clinical assessment for the postgraduate is the adduction would be more than the abduction. Whenever the abduction is limited and adduction is more, clinically you can think that is a case of the coxa vara, where the greater trochanter would be higher and the Bryant's triangle would be reversed with the shortening and limp would be associated with Trenberg test. You must take this is a case of the coxa vara. Very commonly kept case in examination, DNB and MS. One must learn that whenever there is a abduction would be limited and adduction would be double than the adduction. Most of the time it would be associated with the rotational malalignment, where there is an external rotation would be exaggerated, where internal rotation would be restricted, that would be retroversion. But by and large, the rule is adduction is more than the abduction. The impingement sign in case of the 90-degree of hip flexion, we can see about the interrotation. If it is causing the pain, that is the FIR sign would be positive, and that causes the impingement sign positive. One must check in case of the proximal femur hip examination. The abductor strength is very important, as we know that whenever the Trenberg test will be positive, either we need to have a issue with the fulcrum, either we would be having with the lever arm, or either would be having power. So always check about the abductor strength in case of the Coxa Vara. And always examine one joint above and one joint below. Deformity of the knee joint like genu valgum would be secondary to the Coxa Vara. It would be very obvious to have a genu valgum, but it may be secondary to the Coxa Vara, and that would be surprise for the most of the people. So always check in case of the genu valgum, the hip joint adduction and abduction, very quick examination. Check about the limb length discrepancy. Whenever the proximal femur growth arrest would be there, it would be associated with the shortening. Most of the condition in the Coxa Vara would be associated with the limb length discrepancy in form of the shortening. We need to check whether it is a supratrochanteric in nature or infratrochanteric in nature, or a both. So to find out what could be the etiology of the Coxa Vara, is it at a subtrochanteric neck or a intertrochanteric level? How will you assess the radiological assessment? Always check about the X-ray of the hip, epi, and proglateral. Check about the long leg view. Why the radiology is required? In a clinical sense, you need the adduction is more than the abduction, but we need to know the site and severity of deformity, formulate the treatment plan, and predict the prognosis. That is the reason it is required to know about the X-ray. As I said that it is very important to take the pelvis with both hip with the patella facing forward. If it is possible, we can check about the functional alignment in case of the standing view. Always check about the proglateral view with additional radiograph depends on the pathology. The primary pathology will dictate all the requirement of the secondary X-rays. And in case of the standing patient, we can take about long leg view near the maturity or adolescent. What are the radiological parameters we need to check in case of the pelvis with both hips? We need to check about the proximal femur and acetabulum on every case of the pelvis with both hips. Whether the physis is open or a closed, what is the sclerosis, the density of the metaphysis, what is the neck length, neck shaft angle, the head shaft angle, the slip angle, bone quality and congruency of joint, and acetabular changes. This is standard to make that draw a line between the 2 points of the neck, 2 points of the middle of the shaft, and do about the neck shaft angle. And we need to check whether it is decrease compared to the opposite side. Always check on the normal side and say whether it would be decrease or not. Second important aspect is that draw about the horizontal line connecting the both striated, that is hinge and Hiller line, and the vertical orientation of the physis, that is called as the HE angle. This is the HE angle is a very important angle to predict about the prognosis about in case of the developmental Coxa Vara. That is also very important. Whenever we are in doubt, we need to check about the adduction X-ray. In case of the Coxa Vara correction, we are doing about the valgus osteotomy and what would be the position of the future hip. If we want to predict, we need to take about adduction X-ray to know whether it can lead to the uncoverage of the proximal femur after the valgus osteotomy, and that is reason adduction X-ray is useful. Second, adduction X-ray is useful to understand how much amount of the deformity correction is needed when we do about the surgery. And that is the reason adduction X-ray is always needed when you do about the abduction or a valgus osteotomy. This is also another case where you can say the proximal femur geometry is totally disturbed. When we do about the adduction X-ray, there would be uncoverage of the femoral head. In case of the congenital short femur or the PFFD, this is other side of the proximal femur. In fact, the acetabulum correction is required in such cases. What need to check about the long leg view? As a standard, we need to check about the mechanical alignment of the lower limb. You need to check about the neck shaft angle, the proximal femur, as well as the MPFA, the medial femoral proximal angulation, to be checked in case of the long leg view. And always measure about neck shaft angle on both side. Always measure about the MPFA on the both side. What is the implication? Why need to know about the both? We will explain that. This is the, as we discussed, that is a neck and shaft angle. We need to draw a longitudinal axis of the neck, longitudinal axis of the shaft, and measure about the neck shaft angle. And normally neck shaft angle in near the maturity is around 130 degree in adult, and MPFA is 85. So if you see the patient with the MPFA and the neck shaft angle, we need to see about the difference. If the neck shaft angle is less and the difference between the both side on the would be equal, difference of the neck shaft angle and difference of MPM on either side would be equal, that is actually the true Coxa Vara. This I am talking about the adolescent or near maturity. If we see about the neck shaft angle and MPFA, the difference of the neck shaft angle difference would be less than the MPFA, then Coxa Vara would be associated with the greater trochanter overgrowth. Here, the neck shaft angle on affected side is lesser than the opposite side, normal side. But the difference of the neck shaft angle would be less than the difference of the MPFA and contralateral side, then it will be associated with the greater trochanteric overgrowth. What you need to check that if we see the third scenario, the normal neck shaft angle with the MPFA is abnormal, it is abnormal, then it will be the MPFA is reduced on affected side, then that will be pure greater trochanteric overgrowth. So is a three scenario. The neck shaft angle is reduced only, it is the with MPFA is normal, that is actually the Coxa Vara. Where it is the MPFA difference is more than neck shaft angle, but neck shaft angle is reduced, that second scenario will be Coxa Vara with greater trochanteric overgrowth. And the third scenario, neck shaft angle is totally normal, where the MPFA is different than the Etiology, then it is only and only greater trochanteric overgrowth. So after diagnosis, how would you manage? Depends on the etiology of the patient. We can think about the management plan. The management will be required to have the as we said, the first and common disorder will be a congenital Coxa Vara. The characteristic of the congenital Coxa Vara would be associated since birth. It's a part of the proximal femur focal deficit. Most of the cases would be unilateral, bilateral, though it would be there, but it is exceedingly rare. The most of the cases, the Coxa Vara would be common at the subtrochanteric level, though it can happen at the neck and the ossification center, but by and large, the proximal growth plate would not be only a primary cause in case of the congenital Coxa Vara, and it doesn't increase. If it is been treated, it will remain the same if it has been treated. So it is the recurrence of these cases is not very common compared to the developmental Coxa Vara. What are the characteristics of the developmental Coxa Vara? The angulation happens due to the physis, the inclination and orientation and growth problem at the physis. The most of the cases would be bilateral, maybe 1/3 to 1/2, almost 33% to 50% of cases would be bilateral. And despite of the correction, it may lead to the increase in the Coxa Vara, or the recurrence is very, very common. The high rate of recurrence is common with the developmental Coxa Vara. You can see the orientation of the right side, where you can see the H angle is almost 90, where it is tends to progress a lot. Why need to correct the case of the Coxa Vara? Because it can affect, if it has been there since the birth, it can lead to the final shape of acetabulum would be altered because of the poor remodeling of the proximal femur. Stimulus to the acetabulum would be less, so it can affect the final shape of the acetabulum. The altered hip mechanics leads to the abductor weakness and Trenberg lurch, and that will be patient may present with the painless lurch, and a progressive deformity can happen. As we can see, the child was presented around the 13 year and advised the surgery, did not come back for the surgery, it came after the 5 years, and we can see the remarkable deformity progression happens in this child. So it can lead to the progression of the deformity. If it has not been treated, it can lead to the extra articular impingement. You can see the greater trochanter is higher, and with 25-30 degree of abduction, the greater trochanter is impinging on the pelvis, and that can lead to the limitation of the abduction and extra articular impingement. And that is the reason it is necessary to correct the case of the Coxa Vara. And as I said, that it can lead to the secondary deformity like a genu valgum at the knee joint if it is not been treated. Yes, the literature also says for the secondary genu valgum would be due to the primary Coxa Vara. And the last but not least, if the child goes with the same condition and by and large, the child will require the total hip replacement because of the untreated Coxa Vara, the adult surgeon may have the issue with the varus placement of the femoral stem while doing total hip replacement. And that is also necessary to correct about the angular deformity of the proximal femur. What are the aims of managing the proximal femur deformity like a Coxa Vara? To correct the deformity without compromising stability? As I said, whenever you correct about the adduction deformity, when you do about abduction or valgus osteotomy, it cannot lead to the hip instability. Always check before correcting, before planning about the Coxa Vara correction. To prevent the progression of deformity, in case of the growth arrest, that would be the progression of deformity. If it is detected early, we need to do about the progression of deformity by the growth modulation or by the growth modulation of the proximal femur or the greater trochanter to prevent about greater trochanteric overgrowth. To prevent the arthritis, like the incongruency of the proximal femur and acetabulum can lead to the arthritis. So we need to maintain the congruency of the proximal femur and acetabulum in case of the Coxa Vara. What are the variables we need to consider before correction? Because each and every case, when the neck shaft angle is reduced, doesn't mean it do the valgus osteotomy would be sufficient. There would be multiple factors like the age of child, as the child is very young or the child is near the maturity. It depends on that. The implant selection to the planning would be different in a very young child to the adolescent. The etiology, they like the patient present with a post-infective would be totally different than the congenital Coxa Vara or a developmental Coxa Vara. Again, osteopenic Coxa Vara would be dealt with the separate problem. The functional disability, what are the functional disability? Is it only the painless limb or it's a painful limb, whether it is person is having mechanical issues or actually is having the impingement depends on the symptomatology. Functional disability, one can tailor the treatment plan for that, whether the progressive or a static deformity, whether the issue is static or progressive. If in case of the static without any only radiological abnormality, one can decide for the observation, while in case of the progressive issue, one need to do intervention to prevent the progression of deformity and correct the progression of the deformity. The status of the physis is the proximal femur as well as the greater trochanter, whether it is open or closed or it is iatrogenic or early prematurely closed. If it is prematurely closed, one need to treat other as well to prevent a greater trochanteric overgrowth. And the quality of the bone. If the quality of the bone is poor, one cannot decide about the plate and screw fixation because the hold of the proximal femur would be very, very poor. Acetabular dysplasia and joint orientation. One must not forget the congruency of the acetabulum and the hip joint before correcting about the Coxa Vara. The severity of deformity. How much is the severity of deformity? It is mild Coxa Vara, moderate, or a severe. When you are doing about the less than 90 degree of that, it would be quite severe. So the amount of correction would be required is huge, whether it's unilateral or bilateral, because the treatment plan can lead to the asymmetrical problem or a symmetrical problem, whether it is required on either side, like spondyloepiphyseal dysplasia or spondylometaphyseal dysplasia, or unilateral like the developmental Coxa Vara or congenital short femur or the PFFD. It will be associated with limb length discrepancy along the Coxa Vara. Severe may correct about 1.5 centimeter limb length discrepancy, but if it is more than that due to the growth arrest of the proximal femur, it will require about separate correction, either in form of the opposite epiphyseodesis or same side ipsilateral lengthening. What are the various options to treat the Coxa Vara? The observation and follow-up, as I said, it's a static problem, only mechanical problem, or no mechanical problem, which requires about the observation. The valgus osteotomy, very commonly performed for the developmental Coxa Vara. Trochanteric epiphyseodesis is very common to utilize for in case of the, we suspect about the growth arrest of the proximal femur, or it will be do about the preventive for the correction of the greater trochanteric overgrowth. When the child is younger than around 8 to 9 years, it would not be effective beyond the 12 years of age. If the child would be adolescent with established greater trochanteric overgrowth, we can do about trochanteric transfer or the relative neck lengthening or absolute neck lengthening. I'll discuss that point: absolute neck lengthening, relative neck lengthening, and trochanteric transfer. All 3 points for the greater trochanteric overgrowth. Or we can do about the growth modulation of the proximal femur epiphysis. That would be a recent advance in case of the correction of the Coxa Vara. What should we do for the observation? When we'll do about observation, whenever we'll see the remodeling potential is high, when there is a non-progressive deformity and there is a contraindication of deformity. When there's an example as like that, if Perthes has been treated, the neck shaft angle was very less. When wait 4 years later, neck shaft angle is improved, and at 6 years, the neck shaft angle is almost. It's a very young child where there is a growth potential is very high. One should not intervene very early to correct about the Coxa Vara. Second, whenever there is some of the markers, like the person with the neurofibromatosis, or like osteopetrosis, or like the severe the pathology of the primary disease, one should not do correction. It's not only radiological excellence, it should not lead to the disaster for the correction. Coming to the points with the specific pathology like a congenital Coxa Vara, whenever there is the congenital Coxa Vara, you can do about the primary soft tissue release around the hip, like the adductor iliopsoas, and do about the valgus correction and put with the plates and the screws, and do about the lengthening later. Once the varus gets corrected, you can do about the lengthening in a sequential and a stage wise, combined with the opposite, the epiphyseodesis to correct. This is one of the child presented with the PFFT, initially treated with the soft tissue release, with the osteotomy on either side of the hip, and the acetabuloplasty with the proximal femur problem, proximal femur, the valgus osteotomy, and followed by the sequential lengthening. At the near the maturity, the child was having quite stable hip. With the, it will require the one more lengthening to correct about limb length discrepancy. This is another child with the proximal femur is the abnormal, and when it's adduction X-ray, it's required about uncoverage. But the child has been treated with the valgus osteotomy. The child has got the good range of motion at the follow-up. Child is still have some limb length discrepancy. We can see on the right side is just short due to the proximal femur growth arrest. It will require a separate sitting correction for the growth arrest. Second pathology is a developmental Coxa Vara, where there is the issue with the growth arrest at the proximal femur. Growth abnormality, not actually the arrest, but the growth abnormality. When it has been proven the HE angle is less than 25, it will be normal. The HE angle is up to 45, it doesn't progress, but if it is more than the 60, it tends to progress. So the message is that whenever the HE angle is more than 60, we need to require about the correction when it is, and we need to do correction to keep it less than 25. So it can be done with a very early age, but the early age, the issue would be we don't have the very strong implant. So we need to do with the KYS and the spica. The child has got the good correction. Another child treated with the valgus osteotomy and got the good correction at the follow-up, and it's been maintained after the 5 years of the follow-up. But the issue is here is that one need to do a regular follow-up in both conditions to detect the early recurrence. Both pathology, both Coxa Vara can recur in case of the developmental Coxa Vara. So always keep the child in follow-up, always counsel the family for the recurrence of the deformity. Another child, adolescent child, presented with developmental Coxa Vara, treated with the valgus osteotomy, and it's got corrected. In the 6-year follow-up, the child has almost reached to the skeletal maturity, and it's maintained at the skeletal maturity. Coming to the third pathology, the post-infective, that is the child can have the, because of the non-union of the neck, or it will be having growth arrest of the proximal femur, or that would be the growth abnormality of the physis. All three can lead to the Coxa Vara. Here the case, the child has got the non-union of the neck of femur, the child has been followed up, but again we can see there is ossification has appeared, but it did not cross the fracture side. So we decided to do about the fibula grafting with the valgus osteotomy, and the child has got the correction of the Coxa Vara, but again it recurred. So we have treated with the repeat osteotomy, and the child has reached to the skeletal maturity with reasonable neck shaft angle. What should we do in the case of the greater trochanteric overgrowth? Like this is the child with the TRP4 mutation with the spondylometaphyseal dysplasia. The bilateral child has got a greater trochanteric overgrowth, where the greater trochanter doesn't, it works normally, it's a growth normally, but proximal femur growth would not be working as the pace of the greater trochanter. In those cases, the child was advised with the treated with the bilateral greater trochanteric screw epiphyseodesis. A child has been followed up for the 5 years, and we can see about that at the final follow-up, the child has got the reach to the skeletal maturity, and the neck shaft angle is reasonable with greater trochanter, has not moved proximally further after the surgery, and that would be the correction of the Coxa Vara. And this is the final follow-up X-ray. The child has reached to the skeletal maturity. The implant has not been out, but functionally the mechanical pain disappeared. The child is doing absolutely fine at the final follow-up. Few points for the Perthes disease. As I said, if it has been treated with, again, we do about the Varus derotation osteotomy for Perthes disease for the containment, but every single patient we need to do about the 15 to 20 degree of Varus if we do about the containment surgery. More than that can lead to the persistent Coxa Vara, or maybe because of the growth abnormality of the proximal femur, one can have the residual varus or greater trochanteric overgrowth like this. So if greater trochanteric overgrowth happen at the maturity or the after the healing, one can decide about treating about greater trochanteric overgrowth. So there are three different options for correcting about the greater trochanter overgrowth. One of the commonest and the time tested historical is the trochanter transfer. We can cut the trochanter and transfer distally and laterally and fix with the cannulator cancellous screw or the cortical screw. Second option would be a relative neck lengthening. We can do about the cut of the femur in between the part of the greater trochanter. We can remove and distalize and lateralize. So the radiological, it will look better, and there would not be any chance of the extra articular impingement with the relative neck lengthening. Or we can do about the absolute neck lengthening. We can do about that whenever it will be associated with the shortening issue, we can do about the absolute neck lengthening. We can explain all this by this animation. If the greater trochanter is the higher, we can cut the greater trochanter. We can see the the remaining part of the trochanter is still there. We can just take greater trochanter, cut and transfer distally and laterally and fix with the screw. So that would be a case of the greater trochanter transfer. What is the difference between greater trochanter transfer and relative neck lengthening? In case of greater trochanteric transfer, it requires only one osteotomy. In case of the relative neck lengthening, we cut like the greater trochanteric transfer again, but in between part of the trochanter will remove and attach it distally. So there would not be any chance of the extra articular impingement. But again, this will require the dissection of the vessel, the lateral retinacular vessels to be dissected like a safe surgical dislocation approach and do about the relative neck length. Or we can do about actually absolute neck lengthening like the Moschus osteotomy, where it will require about 3 osteotomy, one at the greater trochanter, one at the superior margin of the neck, and third would be inferior margin of the neck. We can uh, do about the lateralize and distalize of the distal fragment and fix with the trochanter and fix with the side plate. Again, the morbidity of this procedure would be higher than the greater trochanteric transfer and relative neck lengthening. But all three would be utilized for the treatment of the greater trochanter overgrowth. Few points on the post-traumatic, whether it is a non-union or a malunion. If it's non-union is required, it will be required to address the non-union like fibular graft or not. If it is a malunion, it will require to do only a plain valgus osteotomy. This is a child treated with the non-union when kept with the proximal femur fixation with the valgus osteotomy. At the final follow-up, the fracture united quite well and child walks without any limb. Another, this is the case of the severe Coxa Vara. The child has got the syndromic condition. The child is treated with the valgus osteotomy with the fixator. The advantage of the valgus osteotomy with fixator in this child, we can see about we can do about the lateralization of the shaft, and that is required whenever the cora is not at the osteotomy site. Always one has to translate the osteotomy in order to maintain the mechanical axis in a right track, and that is the reason it is been treated. The child has got the good congruent hip at the final follow-up. Few points on the dysplasia is a case of the spondylometaphyseal dysplasia, which you can see the corner type of fracture. The child has been treated again like the external fixator with the lateral translation. The last but not the least, the osteopenic pathology. That is, whenever there is the osteopenic pathology like osteogenesis imperfecta or the fibrous dysplasia, the child has got the Coxa Vara, and we can see there is a proximal femur growth is abnormal as well as the density of the bone is abnormal. So if we are going to do the plate and screw fixation, it can lead to the stress riser at the end of the plate. So it has been described by the Fraziers. That is the technique we can do about the K-wires, use the intramedullary node and side. We can fix with the K-wire with the SS wire. The child has got the good correction of the Coxa Vara and it's been maintained in the final follow-up. Another child with the severe Coxa Vara following the fibrous dysplasia, typical shepherd crook deformity, where it's always necessary to keep the intramedullary nail in case of the osteogenesis imperfecta and the fibrous dysplasia. The child has been treated with again the similar technique where the K wires with side SS wire with the intramedullary rod. The child has got the good function at the final follow-up. The slip capital femoral epiphysis, as again, it will be prevention is better than cure. If it has been treated early with that, you can do, but not need for correction about the Coxa Vara. But the established case of the Coxa Vara, we can use about the screw to prevent the further progression with the subtrochanteric or the modified done osteotomy. It's at the site of cora or distally, depends on the primary pathology. Again, it will be a separate topic for the slip capital femoral epiphysis, but I'm not going in detail. This is like a functional Coxa Vara. It's very common to have a hypophosphatemic rickets, where it is common to have a functional Coxa Vara when the child is standing because of the genu varum. There would be Trenberg test would be positive, greater trochanter would be higher, where it is required to correct about the coxa. It's not actually true. Neck shaft angle is normal. However, greater trochanter would be higher, and the patient will be walking with the lurch. The child will require about the sequential stage osteotomy, correct the bilateral femur bowing as well as the bilateral tibia bowing. And if you can see, the mechanical axis would be restored as normal after the surgery. This is the case, the complication of the surgical corrections. That is very common. As I said, the recurrence of the deformity is common. The growth arrest is common whenever there is, that may be the iatrogenic or maybe the etiology of the disease, or the implant related complication would be common after the correction of the Coxa Vara. How to prevent the deform? As I said, the slip capital femoral epiphysis, a patient present very early like this with the very, very mild slip. If you fix with the screws at the skeletal maturity, it's been maintained in same position, and it can not lead to the functional Coxa Vara or a true Coxa Vara. Or we can do about the trochanteric epiphyseodesis. Whenever we do, as I said, the Perthes we do about the 20 degree of Varus, but whenever we do about 20 degree of Varus, we can do about the trochanteric epiphyseodesis in order to prevent about the true greater trochanteric overgrowth. In summary of the Coxa Vara, most of the cases may be due to the physis pathology. It's very common in developmental Coxa Vara. Whenever there is a only the uh, Coxa Vara would be there. You can do about the valgus osteotomy with the lateral translation. When it is Coxa Vara due to the subtrochanteric pathology, you can do about subtrochanteric valgus osteotomy. If there is a non-union of a neck femur, you can do about reconstruction of neck with the valgus osteotomy. Whenever there is a greater trochanteric overgrowth, we can do GT transfer or a neck lengthening, as I said, relative or true neck lengthening or plain GT transfer. Or whenever there is a Coxa Vara with the greater trochanteric overgrowth, we can do about the valgus osteotomy with the greater trochanteric transfer. Coxa breva, that is a short neck, we can do about the neck lengthening procedure. Coxa Vara with severe osteopenia, we can do about intramedullary fixation with the tension band wiring, like I said, it's a Frazier's method. This is an entire summary of the talk for the treatment, whether the Coxa Vara at the physis level, subtrochanteric level, non-union, greater trochanteric overgrowth. It would be combination of the Coxa Vara with greater trochanteric overgrowth with a short neck, or it would be associated with the osteopenia. In conclusion, it's very important to evaluate the age of the child, etiology of the Coxa Vara, bone quality with the Coxa Vara, proximal femur growth plate must be evaluated in every single case to prevent the recurrence of deformity, and timely intervention is required to prevent the irreversible complication. Thank you for your patient listening. Yes, and the last point, all the children must be followed to skeletal maturity, as many of the children will have the recurrence of the deformity. Thank you.
Thank you, Dr. Shah, for that brilliant presentation. Yeah. Thank you, Doctor, for that brilliant presentation. Very comprehensive review of the subject, and because of the wide variety of treatment options. Couple of questions from our side.
Yeah.
Now, when you say developmental Coxa Vara and an indication for surgery, what is a typical HE angle that you look at? Is it, do you have a cutoff value that beyond this particular Hilgenrine epiphyseal angle, you're going for surgical treatment?
Yeah, if it is the HE angle is more than 60, always it requires a surgery. Many of the cases up to the 45, it will require observation, and 45 to 60 is subjective, because it will sometimes it's a measurement error. So what generally we follow that if it is more than 60, the primary it will require the surgery. Less than 60, it may do about observation, and if it is progression, always do about surgery.
Thank you, Dr. Shah, for that. And you have mentioned a wide variety of surgeries for this particular condition, primarily because of the wide etiology as well for this. Now, I just want to review for the benefit of the audience, our residents, fellows, and with an international distribution. I just want to look at this particular slide where you've given all the treatment options. So valgus osteotomy, when the developmental, typical indication would be a developmental Coxa Vara with an HE angle more than 60, right?
Yeah.
Okay. And trochanteric epiphyseodesis, what would be the ideal patient for that? What is the typical scenario where you're going to operate?
In case of the spondyloepiphyseal dysplasia or spondylometaphyseal dysplasia, and when you are not sure about the pathology where there is a proximal femur arrest would be there, we can do about the correction of by doing a greater trochanteric epiphyseodesis. Ideally, less than 8 years of age, it will be good.
And you just put in a screw, is it?
Yes.
And no, technically I'm not an expertise. I mean, I recently did a video for Perthes because I get a lot of these patients, and in that, when you do a video, some of the advocates is that you do an epiphyseodesis, right? So
yeah,
technically you just need to put that one particular screw, is it?
In case of the video, when we are opening actually the lateral side, we do about drilling as well as the screw. But in case of the what I have shown in this patient, with it was just kept no drilling, no epiphyseodesis, no drilling of the physis. It is just kept only one screw. It's like a Matisseur technique for the screw epiphyseodesis.
So you just need to put one screw and that's it.
Yeah. But in case of the Perthes, we do about drilling because either way it is open. So we drill on the lateral half of the physis because we don't want it will grow, and we put this one screw.
Thank you, Dr. Shah. And the other is trochanteric transfer. What is a classic indication where you're going to do a trochanteric transfer?
In case of the mechanical type of the pain, when the patient has got the heel Perthes disease or the post avascular necrosis or any growth disturbance of the proximal femur, either following infection, either following the Perthes, either following the slip, either following the avian, where there is established greater trochanteric overgrowth is there, once disease is already healed, and where the trochanteric epiphyseodesis doesn't work, most of the cases is around adolescent or adult, and it will lead to the mechanical problem, then we can treat it. Not with only the simple cases where the radiological looks abnormal, we don't treat it. If it is associated with the symptoms with the limp, we generally correct it.
Okay, so epiphyseodesis would be somewhere for patients who are at risk for developing an overgrowth, and it'll be somewhere in a slightly younger, right? From 8 or lesser. And trochanteric transfer is slightly older age group where you're expecting a mechanical impingement, right?
Yeah.
Perfect. Okay. I'm just reviewing this so that the audience gets the best of this presentation. I'm sure that's fantastically covered. I just want to review it. That's all. And the other one is relative neck lengthening. What is the ideal indication, or what is the ideal scenario for this particular procedure?
It's actually historically we were also doing a lot of the greater trochanteric transfer, but after the surgical dislocation and the approach, because many times when we do about the osteotomy on the medial side, we don't know about the vessels, and generally it never happen any complication. But now we are doing almost all the new generation surgery, so it will be easy to do about the radiological excellence and no impingement. That's why you need to do. So one can do only greater trochanteric transfer or the relative neck lengthening, either of them, I think.
Okay, so it is a technical or a advancement in pediatric orthopedics where people are addressing the primary pathology.
Yeah, but ideally, it's not only required relative neck lengthening. Many times it will be associated with the safe surgical reduction. But I am talking only on the Coxa Vara, so I just say about the greater trochanteric overgrowth.
Okay, so there is always a technical risk for an iatrogenic avian, am I right?
Yeah, possible to have, but at the same time, relative neck lengthening is quite safe, because if you know the vessel, where is the vessel, and you are going in a safe point, so there would not cause any problem. So both, there is no comparison of the relative neck lengthening and the greater trochanteric overgrowth, but one can choose one of them. It is no difference at all at present.
Okay, and when you compare relative versus the other procedures, absolute neck lengthening in your slide.
Yeah, that is absolute neck lengthening will be required with the limb length discrepancy. He can do about the correction of 1.5 centimeter, 2 centimeter limb length. And whenever we do about the associated Coxa Vara, so this is the third things what we discuss in radiology. If it is isolated Coxa Vara or greater trochanteric overgrowth, the true length, the true neck lengthening will address the short neck as well as the Coxa Vara with greater trochanteric overgrowth.
Okay. And you mentioned about the intramedullary nailing. What is the technical name?
Frazier. That is the JPO. He has published in the particular technique for the correction of the Coxa Vara in osteogenesis or osteopenic condition.
Okay. And the final question is, you mentioned about growth modulation of the proximal capital femoral epiphysis. What is a typical scenario where you're going to do this particular procedure?
Yeah, in case of the following a trauma, it's exceedingly rare. We have done it, but I have not shown because of the benefit of not confusing the postgraduate, because the issue is there very commonly it is used for the caput valgum. That is whenever there is a growth arrest following it's a type 2 avian in case of the DDH treatment, where there is a growth arrest happens following the treatment. And whenever the lateral growth arrest happens, medial side of the physis will grow. And that can lead to the progressive deformity. We can do about one screw on only on medial side of the proximal femur. Similarly, when there is a medial side of growth arrest, that can lead to the progressive Coxa Vara. Then we can do about only lateral side of the growth arrest.
So you just put a screw.
Yes, but that is on the neck, on the proximal physis.
Proximal physis. So that's going to technically different. Okay.
Yeah, it's technically different. That is the reason I am not actually, I removed it. Is hide. It is there in same presentation, but it is hide.
Okay, I just wanted to review because someone who listens to the talk should get the best of this particular presentation. Thank you, Dr. Shah. I think that's all the questions that we have for this session. Thank you for yet another fantastic lecture. And I'm sure this is going to benefit a lot of people all over the world. Thank you so much.
Thanks.